Good afternoon, all. So we are going to have a presentation tailored by Dr. Ashok Sharma. It's called as Tailored Therapeutics Approaches for Corneal Perforations. I am Dr. Rakesh Gupta. I'm President and Director of Public Health Strategic Institute for Public Health Education and Research, Sipher. I'm a former DHS Punjab. So we have tailored therapeutic approaches to corneal perforation. It depends upon the size, location, and underlying cause of the defect. Management is a multifaceted approach involving both medical and surgical interventions, which are aimed at preserving the structural integrity of the globe where possible and also to restore the vision. There can be general medical management, like medical therapy is a crucial adjunct to any surgical plan and is often the first line of treatment. Address the underlying cause. This is paramount for infectious causes. Targeted topical and systemic antimicrobials are used for autoimmune-related meltdowns. We have systemic immunosuppressive agents like oral steroids, methotrexate or sulfur. Cyclophosphamide may be needed to halt the tissue destruction. And for promoting the epithelial healing, this involves frequent use of preservative-free lubricants, punctal occlusion, and or temporary tarsorrhaphy. This is to create a protective, moist environment. And we have aqueous suppressants for very small self-sealing perforations. Aqueous suppressants can increase intraocular pressure and fluid flow through the defect, allowing it to heal spontaneously. We also have anticollagenase agents like oral doxycycline and systemic vitamin C. It may be used as an adjunctive therapy to inhibit the matrix metalloproteinases, which are enzymes that break down the corneal tissue and contribute to the meltdown. And we also have bandage contact lenses, or popularly known as BCL. A BCL can cover small perforations, reduce pain by protecting exposed nerve endings, and provide a scaffold for epithelial healing. Today, we will know about the tailored therapeutic approaches for corneal perforations from Dr. Ashok Sharma. Dr. Ashok Sharma is Director of the Cornea Center, Chandigarh. He is a former Associate Professor, PGIMER, Chandigarh. He has got Cornea Fellowships from LVPEI Hyderabad in 1994. He got it in 1994. And he was eye consultant at Maryland, USA in 1996. He has already published more than 104 research papers. And he has been awarded by American Academy of Ophthalmology in 2009, 2013, and 2015. He has got Best Paper Award SSAI Conference for FIBRIN Glue 1998, Dry Eye in GRA at National Conference 2000, and Chemical Eye Injury by WHO SAARC Conference Nepal in 1998. He has been awarded Himachal Pradesh State Award for the contribution in surgery 2009 and was awarded as Cornea Hero Award by Sipher in Chandigarh 2020. So we can now hear from Dr. Ashok. Thank you, sir.
Good evening, everybody. At the outset, I would like to thank Dr. Rakesh Gupta, President Sipher and ex-DHS Punjab, for giving me opportunity to share some of my experiences in managing corneal perforations and corneal thinning disorders. As we know that corneal perforation is an extremely common problem when we are dealing with the ulcerative corneal disease. It can lead to corneal thinning and finally corneal perforation. Now, there are several terms which are being used clinically, like corneal perforation, corneal fistula, desmatocele, impending perforation, pre-perforated corneal ulcers. You can see various pictures of the same. Now, if we look at histopathologically, all these terms, they mean differently. But from clinical point of view or from clinicians' point of view, they almost are the same because the management strategies they remain the same for almost all the conditions. So we will now look at how this corneal perforation develops. Now, if there is a ulcerative disease, this can be because of the bacterial, viral, or fungal infection, or it can be some non-infective ulcerative disease due to autoimmune disorders. So, in any ulcerative disease, there is a release of collagenolytic enzymes. Now, these enzymes are released by the microorganisms, including bacteria, and they are also released by the stromal keratocytes and also from the inflammatory cells. Now, once these collagenolytic enzymes they act on the collagen fibrils, they lead to degradation of the collagen, and that leads to keratolysis. It continues, then it leads to corneal thinning and finally corneal perforation. So, it is important to recognize this condition, and most of the times the corneal perforations are often missed, and this is considered one of the most underdiagnosed corneal condition. One thing again we have to be very clear is that once we clinically suspect that there is a corneal perforation, we also need to confirm it. Now, clinical suspicion can be because of several indirect signs, like there can be descemetocele, only descemetous membrane is there. So, you do the serial test and you see that there is a perforation. There can be radial folds in the descemetous membrane, again, which is indicator of corneal perforation or impending perforation. Corneal hemorrhage is another sign which like indicates that the perforation may have occurred in the corneal ulcer. If the AC is shallow and the iris is presenting at the site of corneal perforation or corneal thinning, that is 100% sure that the corneal perforation is present. Now, coming to the confirmation by serial test, it is important test, and this was first described by Eric Seidel in 1921. And this continues to be a very important test for confirming the corneal perforation. Now, if we suspect corneal perforation, what we need to do is that we make the patient to sit on the slit lamp and make him comfortable, and you can put a drop of paracaine just to, if he is not that comfortable. And after that, you put concentrated 2% fluorescein dye on that area where we want to detect the corneal perforation. Now, in this picture, we can see that once we have put the fluorescein, there is a dark brown area, and then there is a green lake there. So, this shows that the aqueous leaking through the corneal perforation has diluted the fluorescein, and that gives us the green color under cobalt blue filter. Now, if your fluorescein is very diluted, then you may see, or you are not using the filter, then you may see that there is a brown area, and then you may see the clearing of this brown area. Now, if you are suspecting strongly corneal perforation and still you are not getting the positive test, you may apply a little bit of pressure on the glove, so that if the aqueous has already leaked, you increase the pressure and encourage aqueous to come through that perforation, and we can be sure of that perforation. And in those patients who have dry eye, we need to put a little bit more solution and also some lubricant to so that we can see the perforation. Otherwise, in dry eye, sometimes the dye doesn't spread in the area of corneal perforation and we miss it. Now, as highlighted by Dr. Rakesh Gupta, that for any corneal condition, whether it's infective or non-infective or autoimmune disorder, we need to do the basic workup of that patient. Now, coming to infective ones, like if we are suspecting microbes in the corneal ulcer, then we need to do these tests, like we do corneal scraping. We take out a little bit of material from the ulcer area and then subject it to the gram stain, KOH wet mount smear, bacterial culture and sensitivity, fungal culture, acanthamoeba culture, And if these tests are not positive and we are still suspecting, we go for corneal biopsy. And these days we are also doing a PCR to confirm the infective condition, which infection we are dealing with, and appropriately then we treat with the antibiotics or antifungals or antivirals depending upon the laboratory and the clinical results. Now, coming to the another group of disorders which can lead to corneal perforation, these are collagen vascular disorders. And sometimes, in absence of corneal vascular disorders, also our patients, they may get corneal thinning and corneal perforation. And like this patient has got you can see large area of corneal thinning, and then there is a perforation. Again, this patient is having thinning, dry eye, and rheumatoid arthritis. So these patients need to be investigated for collagen vascular disorders. We need to do all these tests, complete blood counts, then rheumatoid arthritis tests, anti-nuclear antibody, LE cells, and then even for Sjogren's syndrome we look for. So we do all kind of tests to be sure which kind of autoimmune disorders we are dealing. And one thing I would like to clear here is that if a patient is having autoimmune disorder and eye condition, then we refer this patient to the rheumatologist for adequate treatment of the systemic condition, because then these patients, they need, along with eye treatment, immunosuppression and immunosuppressive therapy, which is better monitored by the rheumatologist. Another important point for our colleagues to register is that once a patient has got corneal perforation, be sure that the medical treatment alone is not adequate treatment for this patient. Then we need to do something more. And what more is needed, that depends upon the size of perforation, the diagnosis of the patient, the site of perforation. So all these things are required, but we need some additional treatment to supplement the medical treatment. Now, people may, most of the time what happens is that when we advise a patient with corneal perforation that you have now this corneal perforation and you need either synovial tissue adhesive or some patch graft or therapeutic graft, then sometimes by the colleagues it is said that no problem, I will treat this perforation. Okay, you can treat the corneal perforation, but you cannot prevent the sequelae. Because if we leave these patients untreated or if we don't treat the corneal perforation, patient is bound to develop retinal detachment, choroidal detachment, extrusion of lens or vitreous, endophthalmitis, phthisis bulbi, and finally corneal blindness. So it is important not only to diagnose corneal perforation at appropriate time, but also to intervene and treat corneal perforation instantaneously. Now, if we come to the treatment part, we have several options. For most of the patients who have corneal perforations less than 3 millimeters, they can be treated with the synovial tissue adhesive. And if the patient is having larger perforations, then therapeutic penetrating graft can be done. They can also be treated by patch grafts and large therapeutic grafts. So it all depends upon even the deep anterior lamellar keratoplasty can be done for treating the corneal perforation. So that's what we were discussing, that it depends upon the size and underlying disease which treatment modality we want to use. And that is what the tailored approach in management of corneal perforation is, that we need to customize each modality according to the patient's condition and patient's need. Now, coming to one of the most important therapeutic modality, and that is corneal glue or synovial tissue adhesive. This is basically most important thing in corneal practice. And my mentor, Professor S. Narankari, who is based in USA, Baltimore, Maryland, used to tell me that we cannot sit in a cornea clinic comfortably unless we have corneal glue in our clinic. So that is what how much is the importance of this modality. So you have seen that there is a corneal perforation and we have applied the glue, and this is basically synovial tissue adhesive. Now, this synovial tissue adhesive is basically the one which polymerizes once it comes in contact with the water molecules. Now, the side chain determines the rapidity with which it is going to polymerize. Methyl cyanoacrylate polymerase is very fast, and it degrades and leads a lot of formic acid, which is toxic to the cornea. So it is the butyl derivative which is used, and also octyl derivative which is used. So the longer chain, side chain cyanoacrylate tissue adhesives, they are being used, and these are some of the preparations which are available to us, and we can use these preparations when we are treating our patients. It's important to know how this is applied. The first step is that you remove the slough around the ulcer area or around the perforation area, and then you deep epithelize, means you remove the epithelium surrounding area from the surrounding area of corneal perforation. Now the purpose is that unless you remove the epithelium, the glue will stick to the epithelium and it will come out. So remove the corneal epithelium and then apply glue. We need to dry the area of cyanoacrylate tissue adhesive, and then the fourth principle is that you apply minimum amount of cyanoacrylate tissue adhesive required for the treatment. The method, there are so many methods which can be used. There can be disc applicators, there can be syringes with needles, there can be specialized applicators also, and even toothpicks have been used, or cellulose sponges have been used to apply this cyanoacrylate tissue adhesive. But the method with which I am very comfortable and I would recommend to the beginners is with the syringe and needle. And you can take the insulin syringe, which has a very fine needle, and take a minimal amount of cyanoacrylate tissue adhesive into it, and then after removing the slough, after deepithelizing, and then after drying the area of application, minimum amount of the cyanoacrylate tissue adhesive, by making smallest possible drop, you apply there and leave it there for about 30 seconds or so. It polymerizes, and then you apply antibiotic drop and then apply bandage contact lens. Now this is one very small video just to show how we apply it. Now this patient had multiple corneal foreign bodies which were vertically oriented. So I'm not showing that part, but I'm showing this. You see when we injected ringer lactate into the AC, it came out through the perforation. So this is the perforation. You can see we are putting the sponge and you're seeing there. So now in this case, we are removing the epithelium, and you will be surprised that the epithelium can also be removed by using the cyanoacrylate tissue adhesive only. That we have applied first time the cyanoacrylate tissue adhesive, and then we are removing it. Once we are removing, the epithelium is removed with it only, and then we have applied a very small drop. Now this is looking larger drop because we are seeing it through the microscope, and once it polymerizes, we have put antibiotic drop and bandage contact lens, and that is how the application of cyanoacrylate tissue adhesive has been completed. Now, there are several types of infected corneal perforation which can be treated. Now, you can see this is a post-bacterial perforation, and we have this is a magnified view. We have applied cyanoacrylate tissue adhesive. This is again the magnified view, and we continued with the antibacterial treatment, topical broad spectrum antibacterial treatment, and you can see resultant corneal opacity after healing of the corneal ulcer. So this is again, we should make clear to the patient that see, what we are doing is we are going to save your eye, and once this ulcer heals or perforation heals, you are going to have this kind of corneal scar, and we will have to perform corneal transplant to make you see. So that will be done later on. This is another patient. This was a patient who had a fungal ulcer. He has developed corneal perforation. So we, along with the corneal application of the corneal glue, we also applied the intracorneal amphotericin B in this case, and continued antifungal treatment. You can see that finally it healed very well. So this modality is very important and very good, and we need to use bandage contact lens. But there are certain patients where we do not want to use bandage contact lens, maybe dry eye patients or maybe patients having infections. We are very touchy about that the infection may be aggravated or the patient may develop infection. So what we can do is we can apply glue with a very small and sterile drape. You cut a small piece of the drape and apply glue and then put this drape, or you put the glue on this drape and then apply this drape over to the perforation. So then it beautifully heals. So this is what we did, and in this case, and this was published in Cornea in 2012. This is another very challenging situation, that if you are having a Murray's ulcer, in Murray's ulcer you develop, these are peripheral ulcer, and you develop a corneal perforation. Now, we need to give these patients immunosuppressive therapy. In addition to that, we need to do peritectomy. We have to remove this inflamed conjunctiva. We have to clean the ulcer, and we have to deposit the iris back. And then we have to either do banana graft or something for this. But we have devised very simple treatment of applying glue. But the application of glue is not very simple. You see, there's a large area of perforation. So once we have cleaned the perforation, done everything, we used a very small piece of sclera. And the thickness of the sclera is 1/3 of the total thickness. And a very small customized cut piece is fitted into the corneal perforation, and then glue is applied. So you can see that this is a perforation, and after doing all that, this glue is applied. Once we apply the glue, then we continue the antibacterial treatment prophylactically, plus cycloplegic, plus immunosuppressive therapy, and some steroids also. So once we feel that that now the perforation is healed, you can see, then we remove the glue. Here we have removed the glue. And since this was not fitting well, we have applied 3-4 sutures also. You can see 3 sutures. And then we remove these sutures, and final healing is, you can see there is a large peripheral scar there. But the beauty is that this technique does not induce any astigmatism, and the patient has good vision. This is just a diagrammatic presentation of the same basically, and that we have scleral patch, and then we have a glue, and then bandage contact lens. We have published this paper in again Cornea in 2013, and this is a very remarkable paper, and treatment of ulcers with the Murray's ulcer with the scleral patch augmented synovial tissue adhesion. Now, in case we have adequate thickness, like here you see there is a corneal perforation, but along with the perforation, we have a good thickness of the cornea surrounding. So in these cases, what we do is we make a lamellar pocket, like we are making a lamellar pocket, and after making the lamellar pocket, around say 0.5 to 0.75 millimeter diameter, millimeter larger than the perforation, and then we prepare this scleral patch, and we place this scleral patch into the scleral pocket, then apply a little bit of glue, and this works very well. And this is again diagrammatic presentation of the same. You can see that there is a scleral patch into the corneal perforation, intracorneal pocket, and over that we have a little bit of synovial tissue adhesion. We have a very small video just to show the technique of intracorneal spiral patch supported synovial tissue adhesive application. I would just like to show this one. This is very simple technique, and any corneal surgeon can perform it basically. You can see that we are doing the de-epithelialization of the cornea by using 26 gauge needle, and we can use even the blade also, 50 number blade, or even we can use crescent knife for that purpose. So since this is a like old ulcer, non-healing ulcer, so there is a thickened epithelium around the perforation opening. So once you have done that, then we are making a scleral pocket. This is the crescent knife we are using, and we are making a scleral pocket in this patient. And it's important to make it 0.5 to 0.75 millimeter larger than the actual size of the perforation. And this is how we use the scleral patch, and we procure the scleral patch. So we have made the small skin biopsy punch we use to cut it, and then we thin it, and then we place this scleral patch into the into the lamellar pocket which we have prepared, and now we are applying little bit of glue to just keep it there. So, and with this technique, we are reasonably sure on the table only that this is going to be successful, because even if there is a little bit of collagen lysis, the diameter of the scleral patch is larger, and this is going to stay there. It's not going to cause any issue to that. And once it heals, we remove the glue, and once we remove the glue, the perforation is healed. Sometimes after removing the glue, perforation is healed, but the scleral patch also comes out. This has happened in one patient. And in this patient, then we applied the bandage contact lens, and the patient finally healed very well. Again, this paper we published in Indian Journal of Ophthalmology in 2021, along with the Dr. Rajan and of course Dr. Virendra S. Nankari. This is one of the most challenging case which I have faced, and you see this is a large area of scleral and the corneal melt, and there is a large perforation also, and this has all happened after TGM surgery done by my one of close friends, and it was perplexing that what to do for him, because it's not possible to do penetrating keratoplasty for him. There is no way we can suture the graft, and we cannot do the deep anterior keratoplasty. Again, it's too thin area surrounding. So once we were perplexed, what we did was that we placed a scleral patch, thin scleral patch, just behind the corneal perforation, and just behind the corneal perforation after doing pediphyridectomy, and we applied little bit of the glue, and the surrounding thin area we applied amniotic membrane, and then we continued with the systemic steroids and all that, and it finally healed very well. And this is just again the diagrammatic presentation of the same. And this you can see that it healed very well, and we could save this eye, and we could also restore vision also. He had cataract, we did cataract for him, and finally it was published in a very prestigious journal of ophthalmic and vision research, which is appreciated by many of the readers. Again, we had to treat these patients with corneal perforation and Murren's ulcer, and sometimes it becomes very difficult. And this was during COVID-19 epidemic that we got this patient. Now, this patient is having a large area of scleral melt with the corneal melt with the large corneal perforation, and we did all investigations, and we did not find any underlying autoimmune disorder for him. So he was virtually labeled as amniotic, as a Murren's ulcer patient. And for this patient, again, then we prepared the eccentric lamellar graft using two terfines, and that crescent shaped graft we got, we thinned it to fit into the area of thinning and area of melt, and we were able to suture it both ways, and we were able to form AC. So it was customized according to the size of the perforation, and also according to the width of the ulceration site. The care was taken not to excise the host tissue at all. You just fit the tissue there and do it. So this is final picture. You can see a lot of sutures there, and a lot of, but the patient's central part is very clear. We gave him even initially prednisolone, and then we kept him on methotrexate 7.5 milligram per kg, per week. And once we were sure that after 3 months there is no recurrence, then we stopped the methotrexate and kept him on topical steroids. And gradually the graft cleared, and he had good vision, 6/6 vision at 3 months follow-up. And further follow-up revealed again good vision and he didn't develop any complication because of surgery or because of the disease itself, or because of or there was no recurrence also, and still the patient is under follow-up and it does come and show us. So you can see that good result in this patient. There are some topographic pictures also. Again, sometimes what happens is that you have a perforation, and the biggest problem occurs when the patient is one-eyed. Now, this patient was one-eyed patient, and he had this kind of ulcer, which is very thin. And once we want to intervene, his only question was that would my eyesight go down? Yes, it can go down, because if we put the sutures, there is bound to be some distortion there, and some corneal distortion reason will go down. So what we did was, in this patient, again we used a concentric strip which could be fitted here, did peritectomy, applied amniotic membrane there, and instead of putting now sutures on both sides, we used a FIBRIN glue to fit it, and then we applied one suture here and one suture here. So it was basically a astigmatic deep anterior lamellar banana graft. So it didn't induce any astigmatism. Patient maintained his vision, and the patient's disease was taken care of. So now what our aim in Musen's ulcer is that it's not only to stop the disease. Previously, the aim was only to stop the disease, and we were not able to save his vision or give him vision, because once we do full thickness graft, patient doesn't get good vision because of the gross corneal distortion. So this is what our aim is. Now there is another patient. This lady unfortunately has bilateral problem, and you can see that this is a huge area which is thinned out, and impending perforation is there. The other eye also again similar problem. So in this eye, in which the problem was less, we did peritectomy, and then we did amniotic membrane and topical steroids, immunosuppressive treatment. Patient was comfortable and patient healed well. Whereas the other area, which is a large area and melted everything, there we prepared a lamellar, deep anterior lamellar graft, and we customized it according to the size and length of the ulcerated area, and then we fitted it here. We fixed with the FIBRIN glue, and you can see that this graft is well fitted there, and with the topical steroids, systemic steroids, and finally with the immunosuppressive therapy, patient is doing very well, and patient's vision is not disturbed at all. In both eyes, the patient has got good vision, and patient was extremely happy. So this shows that you need to customize your treatment modalities in these patients depending upon the need of the patient, depending upon the type of the perforation, type of the disease, and size of the perforation. Now, I would just emphasize few points which should be taken care while managing these patients. You clean these eyes properly. Now, this is one of my patients who was wife of a very VIP. He was in police and very high official, and his wife. And you can see that somebody is treating, and I don't know what was his aim. Probably he thought that, okay, it's a non-healing ulcer. You do it like this, and this may act as a tarsorrhaphy. But that was not a medical approach, which should be. We cleaned this, and then we treated, and finally it healed. Now, if you have a infective pathology, you don't go for the conjunctival flap. Conjunctival flap is not meant for that. Unless it's some peripheral ulcer, non-healing ulcer, there you can use pedicle graft, but not for the frank fungal infection like in this patient. Again, tarsorrhaphy is a good option if a patient is having non-healing ulcer because of neurotrophic problem or because of herpes zoster, and sometimes because of post-surgery cerebellopontine angle tumors and all that stuff. But it's not a good option if you have infection, because if the patient is having infection, if you do the tarsorrhaphy, it's very difficult to monitor. The infection will increase, and once the infection increases, you will have to undo the tarsorrhaphy and go for therapeutic and redo tarsorrhaphy. So all those issues will be there. So again, these modalities should be used with caution. We have done a lot of work on corneal ulcers and corneal perforations and synovial tissue adhesives. These are some of the some of the publications which has resulted from that work. The first publication was in 1992. At that time, the tissue adhesive or synovial was not available in India. It was imported from Germany. And one vial used to cost 10,000-15,000. It was very difficult to get it from that place also. And following that, we have published several other articles, important articles. Some of them I have cited. We have also compared the synovial tissue adhesive with the fibrin glue. And we have found that the fibrin glue is better compared to the synovial tissue adhesive. And again, we have a review article where in 2023, where we have all summarized all literature what is available on management of corneal perforations. So with these slides, I want to just summarize that. You see this picture and the camels, these camels you are seeing here. Now these are not camels basically. This is an aerial picture, and these gray shadows, horizontal shadows, they are the camels. So you see, even the pictures can be deceptive. So is the clinical picture of corneal perforation, which can be very deceptive. So you have to be very sure about the corneal perforation by doing the serial test and then manage accordingly. Otherwise, like you are seeing camels here, you will be deceptive. These are the shadows of the camels. Thank you very much for patient hearing. And if there are any questions, I would love to answer these. Thank you so much. Thank you, Dr. Rakesh, for giving me opportunity.
So thank you, Dr. Ashok Sharma, for the wonderful presentation. And it will be very helpful for a general ophthalmologist to know when to refer a patient, or if it is a small perforation, they may manage themselves. But most of the cases, I think they'll have to refer to the corneal surgeons. So you told about the CDLS test, then infective keratitis, then autoimmune disease keratitis, then therapeutic growth. You told about the PKP and the deep anterior lamellar keratoplasty. You wonderfully showed that the CTA in corneal perforation, that is cyanoacrylate tissue adhesive in corneal perforations, how they are helpful. And you also showed some videos of your own and how you treated such difficult cases. And customized DELC for perforated mural ulcer you also showed. You showed some very difficult cases which you managed very efficiently, I must say, that with the recovery of the vision also. Then you also found that now the FIBRIN glue which is available, it was found better than CTA application. So thanks a lot. There's just one question coming to my mind, that when you apply cyanoacrylate adhesive and then you apply bandage contact lenses, so do they adhere, to each other?
No. What happens is that what I told, that the synovial tissue adhesive, once it comes in contact with the aqueous or OH ions, it polymerizes.
Okay.
So it solidifies. And we wait for 30 seconds or so that it completely solidifies.
Okay.
And then we put a drop of antibiotic also, that even if there is some superficial in area, there is some synovial tissue adhesive which has not polymerized, that will also get polymerized with this one. And once we put the bandage contact lens, it will not adhere to the bandage.
Adhere to it, right. Okay. So thanks a lot. And if there are any questions, I'll send it to you on mail.
Sure, no problem. I would love to answer
those. Yeah. So thank you.
Thank you so much.
Thanks.